Hello friends, today I am here to discuss the physiology questions of GT 183. So let's start with the first question. First question asked about which of the following is the major paracrine GI secretion that is responsible for inhibitory feedback regulation of gastric acid secretion. So let's see some things and some concept about the gastric hormones. So the somatostatin and some of the intestinal hormone. So somatostatin and some intestinal hormones, for example CCK-PZ that is cholecystokinin, pancreatozymin, and the secretin, GLP-1, especially GIP, enterogastron. All these hormones, what they do? They will inhibit the gastric acid secretion plus the motility and gastric emptying. They will delay the gastric emptying. All these hormones will all inhibit, first thing, gastric acid secretion, gastric motility or stomach motility, and gastric emptying. These three things they will inhibit. These are the hormones which inhibit these three things. Who are the stimulants? Some other hormones like and the neurotransmitter, the hormones and neurotransmitters, for example gastrin, histamine, ACH, that is your acetylcholine. With that the vagus nerve, that will stimulate the gastric acid secretion via help of the hydrogen potassium pump. Then we can write it as they all stimulate the gastric acid secretion. How? Via stimulating or by stimulating hydrogen potassium pump. Now in option there are two options from the inhibitory hormone. So how we can choose in between them? This somatostatin, they ask about the paracrine hormone. Somatostatin act as a paracrine hormone. Enterogastron, it acts through the blood, so it is not paracrine. Its action is endocrine. Its act through the blood, but the somatostatin, it is act through as a paracrine hormone. So we can write it as somatostatin is a principal paracrine secretion which is involved in inhibitory feedback regulation of gastric acid secretion. And what is the stimulus for that? Increased stimulus for the somatostatin, which is a primary stimulus. Increased H plus ion, that is a stimulus for somatostatin. So increased H plus ions, it is a stimulus for somatostatin release. So answer of our question is option D, somatostatin, because they ask the paracrine GI secretion. If they ask about the endocrine secretion, then we would have gone for enterogastron, but right now the answer over here is the somatostatin. Moving to the next question, question number 2. they ask that which amongst the given substance is absorbed by sodium related co-transport in GI tract. So remember, in most of the things, most of the substances are absorbed in the kidney as well as in GIT with the help of sodium itself. For example, glucose and amino acids and iodide and all those things. So if we have to discuss this about the question number 2. So we can write it as most of the solutes in the kidney, we can write kidney and GIT are transported with sodium ion, which is known as secondary active transport. Why it is known as secondary active transport? For example, suppose if the sodium glucose transporter is working, that is SGLT, it will use the energy of sodium potassium pump. If we have to write it, so we can write it as why it is known as secondary, because they drive their energy from sodium potassium pump. And where this pump is present? Usually it is present on basolateral membrane of the cell. Why? Because in apical, from the apical area, the absorption of the substance is going on. So that's why it is present on the basolateral membrane. If I have to draw a diagram of it, we can draw it as, suppose in the kidney, this is a lumen, and if I have to draw a cell, suppose this is a cell, this is the apical membrane, a lumen, and this is the apical membrane of the cell, and this is the basolateral membrane, or basolateral side of the cell. Then what happens? Suppose we are talking about the sodium and glucose. So what will happen over here? The sodium potassium channels are present, and where they are going? They are going ultimately in the blood. So yeah, so if I have to draw in the blood, it is also having sodium potassium pump. So this potassium is going and this Na is going in the blood, while with the sodium it is activated and SGLT channels are deriving the energy from their sodium potassium pump. And what happens if I have to draw the hydrogen, the transport of hydrogen ion in the kidney? What will happen over there? The hydrogen channels are present. There are 3 sodiums are absorbed, 3 sodium ions are absorbed, and 2 potassium are excreted. So 1 positive ion less excreted. So in to maintain the electrogenic balance, what will happen? The hydrogen will ultimately secreted into DCT and PCT to do the acidification. So that's about the kidney. So what we can write? They are present on the basolateral membrane, since they all dependent Dependent on whom? Dependent on sodium, potassium pump, which is a universal pump. Since they are dependent, so they are known as secondary active transport. All symports are secondary active transport, comes under secondary active transporters. Why? Because sodium potassium pump act as primary. Sodium potassium pump act as primary one. So sodium symporters are always secondary active transporters. If I have to give the example SGLT, we can give the example of SGLT1 which present in intestine of the GAT system, and SGLT2 which is present in kidney. What is SGLT? It is sodium glucose linked transporters, sodium glucose linked transporters, that is your SGLT. These are the example of secondary active transport. Talking about the ORS, they are also containing the sodium ions with the glucose, and if you have to write, ORS contains sodium and glucose, and the super ORS also contain, with these two product, it also contain the amino acid. Why amino acid? So that to increase the absorption of sodium. Why? Because ultimately dehydration is there. As the sodium ions reabsorption increases, the water reabsorption is ultimately increased too. So that's why the answer of our question is all of the above, because amino acid, glucose and galactose, all they are absorbed through the sodium symport. So answer of question number 2 is all of the above. Moving to the next question, not an action of cortisol. Gluconeogenesis, increase free fatty acid, increase eosinophil and anti-inflammatory. Basically over there, here they are asking about the glucocorticoids, not of the all corticosteroids. So if we have to summarize a few points about the glucocorticoids, it is gluco. So name itself suggests that it will increase the glucose level. When the corticosteroids or cortisol is released into the blood, when we are in stress. So when we are in stress, we need more energy. So that's why we need more glucose, and this glucocorticoid help us to give that energy form. So about the glucocorticoids, first of all, they are anti-inflammatory and anti-allergic. Because in the stress we have to concentrate on our problem rather than the inflammation and allergy. So they are helping us, and it is anti-inflammatory and anti-allergic, and they cause, as the name suggests, hyperglycemia via main two processes. How? The gluconeogenesis and glycogenolysis. They also break down the fatty acids, so they do a lipolysis and increases the fatty acid. They increases the fatty acid too. Then what about the blood cells? So we have a mnemonic over here, that is BEL. So they decreases the BEL, as we got over here that they are anti-allergic. So fourth thing, they decreases the BEL and increases all other cells. Almost all other cells. So what is BEL? BEL is B for basophil, basophils, then E, eosinophils, then L is lymphocyte, and they increase the cells like RBC, platelet, they increases the RBC, platelet, then the monocytes, and most important, neutrophils. So we can see that they increases the RBC, monocytes and neutrophil. That means they actually increases the phagocytosis and the immunity. They increases the immunity and increases the phagocytosis. So phagocytosis. So they are not hampering our immunity, rather they are helping us to fight the stress. And it also, fifth, it also increases catecholamines response, mainly via adrenergic receptor. It is known as permissive action. This was the question of last year NEET exam. Yeah, so these all are the functions of glucocorticoids. So answer of our question is option C, increase eosinophils. We had a mnemonic BEL, they decrease the BEL, and that's how they are anti-allergic. So option C is the answer of question number 3. Moving to the next question, fourth question, hyperaldosteronism is associated with all except. So first of all, let's see a few facts about the aldosterone. As we know, aldosterone is released by zona glomerulosa. Zona glomerulosa. What is its function? They activate the sodium potassium channels exchanger. So this when the sodium ions level is decreased, sodium level is decreased, or the potassium level increases, or the stimulus is AT2 is increased by RAS system, what will happen? They will ultimately activate the sodium potassium exchanger in the kidney. What this exchanger will do and where it is located in the P cells. P cells, write down P cells in the CD. They will act on the P cell specifically in the CD, which increases the sodium reabsorption and increase potassium secretion. And we just now saw that they also increase the hydrogen ion. This is if we are talking about the P cell, that they also secrete the hydrogen ions. So acid secretion. Hydrogen ions are nothing but the acid, so they increase the acid secretion too. So they asked about the hyperaldosteronism. As we know now the functions of aldosterone, so we can know what will happen if it started acting too much. So that is known as Conn's syndrome. The syndrome where the aldosterone levels are increased, it is known as Conn's syndrome. What happens in Conn's? Obviously, if it is acting too much, the BP will be increased. Why? Because increased sodium reabsorption, which will drag the water with itself, and it causes the hypervolemia. The BP will increase, that is nothing but the hypertension. The potassium ions, they will decrease the potassium what it will cause? It will cause the more potassium efflux from the cell to in the blood. Why? Because the blood levels of potassium, that is hypokalemia in the blood level of the blood levels of the potassium is falling down. So to maintain the potassium level, what will happen? From the cell, the potassium will release out. So what will happen? Increase potassium efflux from the cell, and that will lead to hyperpolarization, and that can cause flaccid paralysis and also muscle wasting, muscle weakness and wasting. If it is severe, then it can cause flaccid paralysis too. So these are all the symptoms of Conn's syndrome. It also causes the metabolic alkalosis. Why? Because more and more hydrogen ions will release into the urine, and that's why the hydrogen ion concentration will decrease in the blood, and that will cause the metabolic alkalosis. Because we can write it, the reason, because more acid secretion into the urine. We have a symptom like polyuria and polydipsia in the Conn's syndrome. Okay, so over here they ask about hyperandrostenone is associated with all except. They ask about the except. So as we know, hypernatremia, yes, hypokalemia, hypertension it also causes, but it causes metabolic alkalosis, not the acidosis. So the answer of our question is D, metabolic acidosis. Fine. Moving to the next question, question number 5, structure involved in regulation of circadian rhythm. So we know that circadian rhythm, it is regulated through suprachiasmatic nucleus. There are different nucleus. Paraventricular is for the serotonin, and supraoptic is for ADH. So suprachiasmatic is for circadian rhythm. So if we have to know the mechanism of it, so suprachiasmatic nucleus. What we are looking at? We are looking at the circadian rhythm. What is circadian rhythm? It is nothing but the internal, it is also known as internal 24-hour biological clock. It's an internal clock of 24 hours and it's a biological clock. It is actually more than 24 hours. If we have to point out exactly, it is more than 24 hours, but approximately we take it as 24 hours. So what happened? It is also known as sleep wake up cycle regulator. Sleep wake up cycle regulator. So how it act? What happens if the sun is there? That is the external clock. So if we have to write sun as a external clock, this sun will causes the light to fall on our eyes. It causes the light to fall on our retina specifically. What will happen? That will stimulate the suprachiasmatic nucleus, and we got to know that it is a daytime. What happened at the night time then? Night time there is no light, so the pineal gland is activated. So what will happen? The pineal gland is activated. What it cause? It cause the release of melatonin. What is the functions of melatonin? First thing, it induces the sleep, increase or induces the sleep, induces sleep. Then it increases the GnRH, gonadotropin releasing hormone secretion, gonadotropin releasing hormone secretion, and third is circadian regulation, rhythm regulation, circadian rhythm regulation. So this happened during day and night time, and that's how our biological internal clock is stimulated, and it gives us the idea of day and night, and that's how our sleep wake up cycles are regulated. So answer of this question is option C, suprachiasmatic nucleus. Next, moving to the next question, an elderly couple living in a very cold apartment turn on their opened the oven door and went to sleep, leaving the door and window closed. Because there is a cold, they close all the windows and door. What will happen? Poor ventilation is there, and they turned on the oven. The couple was found dead by the neighbors the next morning. Which amongst the following represent the most probable direct mechanism which lead to their death? So what happened over here? They turn on the oven, so CO is formed, the carbon monoxide it is formed, and why? Because there is no cross ventilation, because all the doors and windows are closed. So basically in this scenario what happens? The CO is formed, the carbon monoxide is formed due to poor ventilation, So what this CO causes, what changes CO can cause in our body? CO has 210 times more affinity towards the hemoglobin, 10 times more or higher affinity to hemoglobin than the oxygen molecule. So what happens? It will bind, it will form as well as it will bind very quickly to the hemoglobin. So what will happen? Then it binds to hemoglobin and make what is known as carboxyhemoglobin. Then what will happen if the carboxyhemoglobin is formed? Once the carboxyhemoglobin is formed, the CO has so high affinity, it will not release from the hemoglobin, and whatever oxygen molecules are already attached to the hemoglobin, it will not allow them to release also. So what will happen? The oxygen is already trapped, they are not released, whichever bound to the hemoglobin already before the CO is binding to the hemoglobin, and whatever left oxygen is there in the blood, it is not able to bind to the hemoglobin. So what will happen? Now this carboxyhemoglobin has lowered the binding of oxygen, and it also decreased the release of oxygen. Whatever the oxygen is already bind to the hemoglobin. So they prevented or decrease, or they prevented. So what will happen? The hemoglobin, they act as if the hemoglobin levels are reduced. So we can write it as, this is a scenario of, whole scenario is of anemic hypoxia. This is the main mechanism whenever the CO is there in the environment and which is bind to the hemoglobin. CO also have a property, what it causes? CO also inhibit it also inhibit the electron transport chain and cytochrome P450. Cytochrome P450. What happen if it inhibits this ETC and cytochrome P450? It will cause which anemia? It is a type of histotoxic anemia. It is a type of histotoxic anemia. Then what is a main mechanism? Main mechanism is still the anemic hypoxia. Why? Because the histotoxic anemia, histotoxic hypoxia, this is histotoxic hypoxia. The histotoxic hypoxia occurs at 50 times lethal dose. 50 times lethal dose that of the carboxyhemoglobin that is required to form the carboxyhemoglobin. But before that, the anemic hypoxia will occur and patient will be dead in some time. So, the mainly it is anemic hypoxia rather than the histotoxic, hypoxia. It is mainly the anemic hypoxia. So, they ask about the main cause. So, we can write it as decreased oxygen carrying capacity of blood. So, option over C is the answer of our question number 6. Moving to the next question, heme is converted to bilirubin mainly in, okay fine. As we know that heme is converted to bilirubin mainly in the spleen, liver and the bone marrow. Spleen, liver and the bone marrow. How they are converted it into the bilirubin? By the help of the macrophages of the reticuloendothelial system. We do have a diagram for it. Reticuloendothelial system. Okay. Reticuloendothelial system. Fine. This is a reticuloendothelial system. What happens? The heme containing compounds, that is the hemoglobin, myoglobin and the cytochromes, as their lifespan is over, they go into the spleen. What will happen? They break down and they will release the heme. As the iron and carbon monoxide is released with the help of heme oxygenase, it will convert into the biliverdin, and with the biliverdin reductase, with the help of biliverdin reductase, it will convert into the unconjugated bilirubin in the spleen itself. Then what happened? With the help of albumin, it is transported towards the liver. Because the bilirubin cannot go itself in the plasma. So, it needs the help of albumin and it transferred it towards the liver. Then with the help of GST, what is GST? It is glutathione S transferase. With the help of that, it will send to the endoplasmic reticulum of the liver cells, hepatocytes, and there how it is converted to bilirubin monoglucuronide. With the help of UDP glucuronic acid, that is uridine diphosphate glucuronic acid. And then onwards, it is ultimately converted to conjugated bilirubin via the steps like two bilirubin monoglucuronides and bilirubin diglucuronides. Ultimately, they conjugate and they will form the conjugated bilirubin. With the help of canaliculi, it is released again into the blood and into the duodenum in the form of conjugated bilirubin. Once this conjugated bilirubin is entered into the duodenum, it will carry forward to the distal small intestine and the colon, and there how it is excreted in the feces and the urine. In the urine in the form of urobilinogen, and in the feces in the form of stercobilinogen. The renal excretion is there, but some amount of this conjugated bilirubin is again entered into the liver via help of enterohepatic circulation. But this is the mechanism of bilirubin formation, synthesis and excretion. But they ask about the bilirubin formation, it is already done in the reticuloendothelial system, and spleen is nothing but the part of the reticuloendothelial system. In the lymph node there is no much breakdown, so the answer will be C, spleen. The answer is C, spleen. Converted to bilirubin. They didn't ask about the form, so the answer will be C. If they specifically ask about the conjugated bilirubin, then our answer will be liver. But now the answer is C, spleen. Okay. Question number 8. Area of tongue shown in the illustration in the zone of what test? Okay. We do have a diagram. The old concept says that different areas have a different specific type of taste buds which can sense the specific type of taste sensation. But the new concept says that in all the areas we can sense or we can perceive all kind of taste sensation. So the old concept says that from the anterior part we can taste the sweet sensation, sweet from the anterior part, sour and salty from the lateral part. The white part that is over here, we can taste the salty taste sensation, and from here that is sour sensation, and bitter from the posterior part, If you have to write down the specific type of taste buds which can perceive this specific type of taste sensation, we can write it as it is through tongue papillae. It is through tongue papillae, or which is also known as taste buds. Specific areas have specific taste buds. For example, foliate, papillae in the lateral part, lateral surface, then the fungiform papillae, in the anterior part, anterior surface, then the circumvallate, which is in the posterior part for the bitter taste sensation, and the filiform, which is in the mainly dorsal side for the salt sensation. But the filiform is very less active in the human beings. And some more points about the taste sensation. There is one 4 old test which we saw just now, and one more test, umami test, which is recently experimented. So we can write it as, we can make a chart, taste and the mechanism or the substances by which we can get this specific type of taste sensation. So starting with the salty taste sensation, it causes due to ions of alkali, metal, and the ions like sodium chloride. Because of them we can sense the salty taste sensation. Coming to the sugar or sweet sensation, whenever we are eat anything sweet, what happens? They activate the GPCR proteins, G protein coupled receptors, and via cyclic AMP we can taste the sugar. It can also caused by some organic molecules like, for example, aspartate. These are the sweeteners, but they don't have or have minute amount of glucose. So they will not increase the glycemic index, but they have sweet sensation. Coming to the next sensation like SAR sensation, we can sense it from the citric fruits, or we can write it as acid or H plus ions, acid or H plus ion. Remaining test is bitter. Bitter can be tested via quinine, and most poisonous substances like cyanide, especially the cyanide. They test bitter, and this bitter wala mechanism, is also go as if the sweet mechanism. They also activate the G protein couple receptor, but at the posterior end of the tongue, and they also activate the cyclic AMP, and through that if these kind of substances are ingested, they will give us a bitter taste sensation. The new test which I was talking about, it is umami, and it comes through the monosodium glutamate. Monosodium glutamate. This was the question of NEET exam 2016. So they ask about the umami taste sensation. It comes with the monosodium glutamate. It is invented by the Japanese people through the Ajinomoto. So answer of our question is whatever they shown over here, that is for salt sensation. So option B is the answer of our question. Moving to the next question, which of the following food substance required chewing for the digestion? Basically all food substances need the chewing, but what if we swallow it without chewing? So over here the cheese and eggs. Cheese is very soft, and the eggs are usually they are talking about the raw eggs. They are in the liquid, semi-liquid form, so we can swallow them directly without chewing. We have to see the funda about the vegetables and meat. The answer over here is vegetable. Fruits and vegetable, they have a cellulose coating, which is we cannot, if we don't chew, the nutrient portion inside the cellulose membrane, we cannot digest it. So let's see the funda about the vegetables and why the answer is vegetable rather than the meat. So write down what happened. Chewing is important for all solid substances, but especially for the vegetables and fruit. They have cellulose coating. They have indigestive cellulose membrane, which is surrounding the nutrient portion that must be broken down. For what? To get a contact with the digestive part inside. So broken down to allow contact with the digestive enzymes. Remember, in the mouth we have amylase. Which can break down the carbohydrate and starch. This carbohydrate part is the nutrient part which is covered in the cellulose membrane, which can be broken down only in the mouth. Why? Because the amylase is absent in other digestive organ or the lumen. It is only present in the mouth itself. So what will happen once it is broken down? What will happen? The amylase, with that we can break down the cellulose membrane which is present in on the vegetables and fruits, and that's how we can chewing, with the help of chewing we can break down the cellulose membrane. What about the meat then? The meat mostly contain protein part, mostly it contain protein part. We don't have any enzyme to digest a protein inside the mouth. Even if we swallow the meat itself, if it is in comfortable size, if we suppose we swallow the meat itself, and ultimately it will go through the esophagus into the stomach, and stomach do have HCl and various amount of hormones and various amount of enzymes that will break down the protein, mainly the protease. But in the mouth we don't have the enzymes to break down the proteins. So even if we don't chew the meat and swallow it, ultimately it will go into the stomach and break down, but that will not happen in the case of vegetables and fruits. So answer of this question is vegetables, option C. So moving to the next question, they ask about the amongst the following alternative, which hormone is primarily responsible for skeletal maturation of long bones during puberty. So in males and females we do have sex steroids which activated in the puberty time. So what happened at puberty? At puberty, epiphyseal closure will occur, and it is mainly because of two hormones. They are the estrogen and testosterone. Estrogen and testosterone. These are the sex steroids. As the maturation of gonads will take place in the puberty, these hormones are starting getting released more and more. What happen? They will cause the epiphyseal closure, but mainly it is because of the estrogen. It is mainly because of the estrogen. Why? It have a significant effect on the osteoclast as well as osteoblast. So just if we have to enumerate, estrogen are main factor to cause the epiphyseal closure, and bone maturation, and that's why the height will not increase further, and so the height will not increase further after puberty, because they cause the epiphyseal closure. Why the estrogen are main? The functions of the estrogen, because estrogen affect the generation, lifespan, and functional activities of osteoclast as well as osteoblast. It causes the functional activity of, it control osteoblast. So how it controls? Let's see. First of all, they promote synthesis of osteoprotegerine. Next, they increase the osteoclast apoptosis, and as well as they decrease the osteoclast formation and activity. Why? This will cause they will conserve the bone mass. That's how they conserve the bone mass. So these many activities related to the bone, it is caused due to the estrogen. So answer of our question is obviously estrogen. So answer of our question is B, estrogen. Moving to the next question. Next question is all about which type of breathing is shown in the below image. Remember, this is a typical type of breathing, which is typical type of pattern rather. It is crescendo, decrescendo pattern of breathing. This was the AIIMS exam question, that crescendo decrescendo pattern of respiration is seen in. It is Kindstalk breathing, or it is also known as diamond shape breathing pattern. Is also known as diamond shape breathing pattern. So it is seen in Kindstalk breathing. So answer of this question is D, Kindstalk breathing. Why this crescendo decrescendo pattern occurs in Kindstalk breathing? Let's see some facts about that. So Kindstalk breathing, or Kindstalk respiration, it is usually seen in high altitude, or the person is voluntarily doing hyperventilation. So voluntary hyperventilation, as well as in the sleep, These are the physiological causes. These are the physiological causes of Kindstalk breathing. Then if we saw the physiological, let's see few examples about the pathological also. Pathological causes, what are those? They are the LV failure, left ventricular failure, uremia, then the brain damage, and the congestive heart failure. These are the pathological example of Kindstalk breathing. What actually happens in Kindstalk breathing is, whenever the patient does hyperventilate, suppose the patient does hyperventilation, once he started hyperventilation has occurred, what happened? The carbon dioxide will wash out from the body, more and more carbon dioxide will be excreted. So carbon dioxide wash out, that will ultimately lead to apnea. So what happens if the apnea is there? Again the respiratory centers are stimulated, and through that they will cause the apnea. Next, what will happen? For few time there will be the apnea, and that causes the decrescendo pattern because of the hypoxia. Hypoxia will be there due to apnea. What will happen? This, whenever the hypoxia is there in the body, what will happen? They will stimulate the chemoreceptor, which are present in the aortic and carotid bodies. So they will stimulate the chemoreceptor. Through the chemoreceptor, what will happen? Patient will again start to hyperventilate. They stimulated they triggered the chemoreceptor, and they will hyperventilation will goes on. This cycle will go on and on and on in the Kindstalk breathing, whenever there is especially in high altitude areas. So this is the Kindstalk breathing, and this is the mechanism from crescendo decrescendo pattern of Kindstalk breathing. Then they gave in the option Biot's breathing. What is Biot's breathing then? Biot's breathing is irregular respiration with the spells of apnea, and it is seen mainly in brainstem injury. It is seen in brainstem injury. So this is the about Biot's breathing. It is irregular kind of pattern. There is no such pattern, specific pattern in the Biot's breathing. It's irregular respiration. While there is a pattern, crescendo, decrescendo or diamond shape pattern in the Kindstroke breathing. Okay, moving to the question number 12. The earliest physiological response to hypoglycemia. So remember, all hormones causes hypoglycemia except the insulin. So option A is the answer of our question, decrease insulin secretion. All other hormones are increased because they cause the hypoglycemia. They cause the hypoglycemia, but first change should be the decrease in insulin level. Why? We will just see now. What happens? Only one hormone, only the insulin, only one hormone causes hypoglycemia, that is insulin. It is a golden line in the endocrine. All other hormones causes hyperglycemia. All other hormones causes hyperglycemia. So whenever there is a hypoglycemia, first change that occur, that is decrease in insulin level, then the other hormones are increased, then the counter hormone, then afterwards or after that the other hormones, other counter regulatory hormones will increase. They will increase. Let's see some examples like growth hormone, glucagon, epinephrine, then the cortisol, they will ultimately increase and they will cause, what they will cause? They will cause glycogenolysis and gluconeogenesis, and that's how they cause the hyperglycemia. But the first change should be decrease in insulin level. The first change should be decrease in insulin level. So answer of our question is A, decrease in insulin secretion. Moving to the question number 13. Compared to plasma, cerebrospinal fluid has reduced concentration of. Remember, everything is more in the CSF except few things. So let's see. Let's see the chart. We do have a chart for it. Few things is more in the CSF. Few things are more in the CSF. All other things are more in the plasma due to blood-brain barrier. Blood-brain barrier will not allow everything inside to come inside the brain. So what are those things? Those things are magnesium, which are more in the CSF. Magnesium, chloride, carbon dioxide and bicarb. These are the four things we can see over here, that magnesium, chloride, bicarb and the PCO2 levels are more in the CSF rather than as compared to the plasma levels. All other things like sodium, potassium, you can see the sodium levels are more in the plasma, the potassium levels are more in the plasma, the calcium levels are approximately double in the plasma. Then all other things including the pH and the proteins and the glucose, all other things are more in the plasma, but except the magnesium, chloride, carbon dioxide and bicarb. So answer of our question is plasma, and they ask about the reduced concentration. So we know that bicarb chloride and carbon dioxide are more in the CSF. So they ask about the reduced concentration. So answer of our question will be glucose, which is more in the plasma rather than the CSF. Moving to the next question, question number 14. A patient with the lung carcinoma was operated and lobectomy was done. Over here, the lobectomy is done after surgery. Which parameter increases? They ask about increase. There is a slight misprinting over here in the option number D. It should be not FEV1, it should be FEV1 percentage. It should be FEV1 percentage. All things will decrease in the patient which have already the lobectomy has done in that patient, but only one thing that is FEV1 percentage. So let's see funda about it. What is the actual funda about this respiratory volumes and capacities? What happen if the lobectomy is already done in that patient? So after removal of the lobe of the lung, all volume and capacities are nothing but the summation of two or more volumes. All volumes and capacities are decreased or reduced. Then as a result, what will happen? As a result, static compliance also decrease. Static compliance is also decrease, but the specific compliance will remain normal. Why such thing occur that specific compliances remain normal and the static compliance decrease? Because the static compliance depends on lung size and stretchability. While the specific compliance, it depends on only stretchability, only on the stretchability. So that's why it will remain normal. So what are all volumes that are decreased? All volumes are decreased or reduced, including dead space, VC, IRV, ERV and all those things. But the specific compliance, what are the example of? These are example of static compliance. And what are the specific compliance? The FEV1 is also reduced, but the FEV1 percentage, since it is a ratio, it will be normal. Since it is a ratio, will remain normal because it is a ratio. If both numerator and denominator is decreased, FEV1 percentage is FEV1 upon FVC. So both are decreased, so ultimately the ratio will remain normal. So that's how the FEV1 percentage will be normal. So answer of our question is D, FEV1 percentage. It is not FEV1, it is FEV1 percentage. Moving to the next question, question number 15. A pulmonary circulation differ from systemic circulation in the way that it has. So if we have to see the funda about the pulmonary and systemic circulation, what we can do is cardiac output. As we know, we have one heart and it is pumping at the same time, same volume in the both ventricle. So cardiac output is same in both. Which both? The pulmonary as well as systemic circulation. Pulmonary and systemic circulation. It is same in both. It is equal in both, that is 5 liters per minute. So what will happen? But the resistance in pulmonary circulation is less. So low resistance. Why low resistance over here? Because it is a shorter route. Why? Because it is a shorter one. It is a shorter circulation as compared to the systemic circulation. So what is the formula of resistance? It is equal to, by our Poiseuille-Hagen law, we can derive the formula, that is 8 eta L by pi r raised to 4, where eta is the density, L is the length and r is the radius, and the capital R is the resistance. This is a radius and this is the resistance. So to maintain the blood flow, it requires low pressure. Obviously the resistance is low, so low pressure is required in the pulmonary, since low resistance or low resistance, it require low pressure too. So low resistance and low pressure. So 5 liter of blood enters into pulmonary circulation. Then how it accommodates whole 5 liter? Because it have a stretchability. So pulmonary circulation, and what happened? They are very in the pulmonary circulation, the pulmonary vessels are very stretchable to accommodate this blood, this 5 liters of blood. So if we have to summarize this thing, so for the pulmonary circulation, pulmonary circulation, it is low resistance that we saw, low resistance, low pressure. They can stretch more, that means they have a high compliance. And if we compare, it is having a high flow at a particular time. Because they are stretchable, they can accommodate more blood. So over here it is option B, low pressure, high flow and high compliance will be the answer. Okay, moving to the next question, question number 16. Given image show waves of JVP, in which clinical condition are you likely to find the most prominent wave shown in 1? So there are different waves are shown, 1, 2, X, 3 and Y. Actually if we have to draw or we have to see in this particular diagram, it is a wave, then this is a C wave, this is a C wave, this is a X descent and Y descent, and this is a V wave. This is a V wave. We do have a diagram for it, I guess. Yes. So they ask about the prominent A wave and the condition. So we just gonna discuss this topic. So this is the A wave, C wave, X wave, V wave and Y descent. So let's see what is a funda about these all waves, how they are formed and in which condition they are increased. So if we have to write, first of all we will see how the waves are formed. So the A wave is formed due to the atrial contraction. Basically what we do while recording the JVP, we will put the transducer in the neck vein, that is a central venous, to check the central venous pressure, and it is come through the right atrium, it comes to the right atrium. So as the atria contracts, the blood will be flow towards the JVP, that will increase the JVP, that will flow towards the neck vein, and that will increase the JVP. It can be sensed through the transducer. So in A wave, whenever the pressure in the atria will be increased, the waves will give the positive deflection, and whenever the atrial pressure is decreased, it will give the negative deflection, that is a negative wave, X and Y descent. So A wave is caused due to the atrial contraction. Then your C wave, it is due to the TV bulging, tricuspid valve bulging, tricuspid valve bulging. Then the X descent, it is due to atrial relaxation, Then V wave, it is due to passive atrial filling, it is due to passive atrial filling through the vena cava, superior and inferior vena cava, and then Y, once it is filled, the atria will be emptied in the ventricle, so atrial emptying. So atrial emptying. These are the causes of JVP. So what happened in different condition? A wave. They ask about the A wave. Depends on the atrial contraction. As we know, it is depend on the atrial contraction. So in atrial fibrillation, the A wave is absent. Why? Because atria is not able to contract properly. It will not able to contract properly. It will just contract partially. So the transducer not get the impulses. So the A wave is absent in atrial fibrillation. What happens if the pulmonary hypertension is there or tricuspid stenosis is there? Tricuspid stenosis or pulmonary hypertension is there, what will happen? The A wave will be prominent. It is prominent. It is very big A wave, which is known as giant A wave. It is very big A wave, so it is known as giant A wave, or it is also known as cannon wave. It's known as giant A wave. Giant A wave in complete heart block. What will happen in complete heart block? In complete heart block, when the atria contract, the ventricles are relaxing, the tricuspid valve is not open, so there is AV dissociation. In complete heart block, there is AV, atrioventricular dissociation. Atrioventricular dissociation. What it will lead to? Once the atrioventricular dissociation is there, the atria contract, but the AV valve remain closed. The AV valve remain closed, where the entire blood will enter into. The entire blood regurgitate to JVP. They ultimately regurgitate to JVP. So we are going to get the prominent, high, very high A wave, very big A wave, more than the giant A wave. It is prominent more than the giant A wave, which is known as cannon wave. Cannon A wave. And what is the cause for it? The cause is AV dissociation. AV dissociation. So, answer of our question is option D, complete heart block. In complete heart block, as we can see over here in the diagram, this is a giant A wave, and this is your cannon wave. cannon, A wave. Giant and cannon, A wave. Moving to the next question, question number 17. According to the Poiseuille's law, the most influencing factor affecting the blood flow is, what is Poiseuille's law? Poiseuille's law. Let's see. Poiseuille's law. So, yeah, Poiseuille's law says that the flow rate of blood is equal to pi r raised to 4 upon 8 eta L into pressure gradient. This was the law given by the Poiseuille-Hagen, where the eta is viscosity, the L is the length and the radius. So, as we can see over here, the radius have fourth power. The flow rate is inversely proportional to the viscosity and length, but it is directly proportional to radius of the blood vessel, and it is not only directly proportional, it have the fourth power. So, suppose if we increase, suppose the R is equal to 1, so the flow rate will be 1 again, but if we increase the radius twice, if the radius become 2, then if the radius become 2, what will happen? The flow will be increased by not only 2 times, it will increase the 2 raised to 4, that is 16 times more. If we increase the radius diameter by twice as it was before, then it will increase, the flow will increase 16 times. If suppose we do we further increase the radius diameter and we do it as 3, then flow will be increased 3 raised to 4 times, that is it will increase by how many times? It is increased by 81 times more. All other factors will affect. So, if we increase the radius by 2 times, the flow will be increased by 16 times. If we increase the radius by 3 times, the flow will be increased by 3 raised to 4, that is 81 times. So, that is why the radius plays the greatest role in determining the flow rate, the blood flow or flow rate. So, answer of our question will be C, radius. Moving to the next question, which of the following is principal function of the bones of the middle ear? So, what bones actually does, we have to know about the air conduction and bone conduction. As we know, the air conduction is more than the bone conduction in normal subject. Why it is so? Because of the effect of amplification. Why and how does amplification occur? Because the area of tympanic membrane is 13 times more that of the area of oval window. So, area of tympanic membrane is 13 times larger than whom? Than the oval window. So, what will happen then? The acicular conduction, the traction by handle of Malleus, that will cause the sound to amplify 1.3 times. So, 13 into 1.3 times, that is 17 times the sound is amplified whenever it is coming through the air conduction, that is through the tympanic membrane and ossicular chain, malleus, incus and stapes, and then it is going to the oval window. What happens to the bone conduction? In bone conduction we are directly stimulating the oval window through the basilar membrane. So that's why the amplification effect will not be there. So it is, and what this phenomena is known as, it is known as impedance matching. It is known as impedance matching. So the sound is twice louder in A conduction and twice more in the duration, because it is going through the ossicular chain. So over here they gave that they provide mechanical support for the flexible membrane. Actually no, it causes the amplification of sound. They reduce the amplitude. No, actually they increase the amplification, and they increase the efficiency of vibration through the middle ear. Yes, because in the middle ear all these ossicles are there. So option C is the correct answer. They control the opening of scission tube and allow the pressure to be equalized. Not really. The scission tube, it is controlled by the air pressure, not through the ossicles. So option C is the answer of our question. Moving to the next question, in the graph below, what are the X and Y? This is the normal graph. It is a normal graph. Then in X, this is a lung volume. In X, the graph of X, the lung volume is increased. That means the air trapping is there. X may, what happened? Air trapping is there. Why? Because due to increased compliance. Increase compliance in the lung. And in the Y, there is a decreased compliance. So lung volume over there is lesser. In all other diseases, if we have to write it down, in X, very high compliance. In which condition it occurs? It occurs mainly in emphysema. Remember, there is only one disease, mainly the emphysema, where the compliance is increased, while in all other diseases, there is a decreased compliance. Most of the diseases there is a decreased compliance. In some diseases, in almost all, we can write almost all, and in some diseases the compliance is normal. So the X graph suggesting the RLDs, if we have to specially talking about the RLDs, which is restrictive lung disease. What happened in restrictive lung disease? The compliance is decreased. This is a typical example of restrictive lung disease. All the occupational diseases, asbestosis, silicosis and all those, they are the restrictive lung diseases. So what happened? X, we know that it is an emphysema. So answer should be either A or B. But in chronic bronchitis, what happened in chronic bronchitis? The compliance is stretchability and air trapping is not there. The compliance is normal. In the chronic bronchitis, the compliance is normal. So the answer is option B. So answer is option B, emphysema in single lung. What happened in single lung? Obviously, the amount of air coming inside is half of the amount that would have come inside if there are two lungs. So that is very easy. So the answer of our question is option B. Moving to the next question, action of GLP or all except. So quickly let's see the action of GLP. Action of GLP. What is GLP? It's glucagon like peptide 1. If glucagon like peptide 1. Where it actually comes from? It comes from L cells. It comes from L cells of GIT, which is duodenum and especially jejunum. Intestines, from the intestine, that is duodenum and jejunum. What it causes? It causes increase in insulin secretion, decrease in glucagon level, So it is, if we have to see the clinical relevance of the glucagon like peptide 1, it is very effective in diabetic patient, Why? Because it is increasing the insulin secretion and decreasing the glucagon level. That means it decreasing the ultimately the glucose level. So it is effective in diabetic patients, and this is the analog of GLP-1 can be used as treatment for diabetes mellitus. This was the regarding this, the question was asked in NEET exam in 2012. So yes, we can use the GLP-1 analogs and as the diabetic treatment. So answer of this question is C. It increases the insulin release, yes. It decreases the glucagon release, yes. It have to decrease the glucose level, and they ask about the accept. So these two are the functions. It increases the gastric emptying? No, it delays the gastric emptying and reduces the appetite. It causes satiety, it gives the satiety feeling, and that's how they reduces the appetite. So answer should be C, increases the gastric emptying. So that's all for the physiology GT 183.